Welcome once again to my session, Surgery for Undergraduates. Today's topic is on lower GI bleeding, which is a continuation of last week's topic of upper GI bleeding. GI bleeding can be divided into upper and lower GI bleeding. Okay, and the demarcating point is the attachment of the ligament of treats at the duodenojejunal flexure. Anything proximal to it is considered upper GI bleed, and all bleeding distal to that ligament of treats is considered lower GI bleed. I've covered adequately in the last lecture on upper GI bleed. Today, we shall talk about the lower GI bleed, which is bleeding from the DJ flexure right to the anorectal region, which consists of the small intestine, large intestine, rectum, and the anorectal region. Normally, the stools contain some amount of blood which is secreted or lost daily in the stools. It is estimated that 1.2 ml per day can be normal. The significant loss is when it reaches 10 ml per day. If there's a loss of 10 ml per day of blood in the stool, it is pathological and needs to be investigated. The most important presenting feature is hematochezia, which is actually fresh bleeding per rectal. It can be bright red if it is an arterial source and the bleeding can be brisk, or venous and the blood is dark in color or dark red in color. This diagram shows the setup of the lower gastrointestinal tract where the bleeding takes place. On the left, highlighted by this green ink here, are the 4 common causes from the small intestine and ascending colon. These include angiodysplasia in the right or ascending colon, diverticular, which is not so common, carcinoma of the cecum, which often presents as occult blood, and Meckel's diverticulum from the terminal ileum, which is more common in children and young adults as a source of lower GI bleed. On the left here, highlighted by this blue color here, are the 4 common causes of bleeding from the left side of the colon: ischemic colitis, carcinoma of the ascending colon, polyps of the descending colon, colonic diverticular involving the sigmoid and descending colon, and at the terminal end of the rectum and the anal canal, you have solitary ulcer of the rectum, anal fissures, hemorrhoids, which are common, and inflammation of the rectum and the colon, which can be either Crohn's disease, ulcerative colitis, infective causes, or radiation colitis. I have to remind you that the important condition of dengue fever as a cause of lower GI bleed. This is especially so in children and young adults. In our country, where dengue is endemic, this condition should always arouse suspicion of the cause of bleeding. This table lists the common causes of lower GI bleeding according to the site. Colonic bleeding accounts for 95% of the bleed. of the bleeding cases with diverticular disease, anorectal diseases, especially hemorrhoid, neoplastic lesions, polyps, and cancer, and angiodysplasia being the most common 4 conditions affecting or as a cause of lower GI bleed. On the left, the smaller intestine contribute only 5% of the bleeding cases, and of interest is Meckel's diverticulum, which occurs in young adults and children, and in older individuals you have miscentric ischemia. All the other causes do occur from time to time, but not so common. Common causes of lower GI bleed. These are the 5 most common causes of lower GI bleed in our country: diverticulosis, angiodysplasia, colorectal cancer, colitis of various causes, inflammatory cause, radiation, ischemic, and anorectal causes, especially hemorrhoids, cancer anus, fissure in anus, and even fistula in anus. Of course, as mentioned, dengue fever should not be forgotten as a common cause of GI bleeding in our patients. The low platelet count is an indicator of the possibility of passing stools with blood stain. Incidence by age group is another important source, or even important as a cause of diagnosis. Adolescents and adults, you have Meckel's diverticulum, inflammatory bowel disease, and polyps as the common causes in that age group. Adults to 60 years of age, the common causes include diverticular or diverticulosis of the colon, inflammatory bowel disease, and neoplasms. Whereas adults over the age of 60, the common causes are arteriovenous malformations such as angiodysplasia, colonic diverticula, and carcinoma of the colon. What are the symptoms of the main symptom of lower GI bleed is bleeding in stools or passing blood in the stools. And this stool, passage of stool in these blood-stained stools, you must be able to differentiate the relationship of the bleeding to the defecation. It can be initial, which is before defecation, and in these cases are usually external causes, anal fissures, trauma to the perineal region, and abscesses around the anus. It can be terminal, that is bleeding occurring after defecation, which is classical of hemorrhoids. And most commonly, it is usually mixed with the stools. Okay, and this usually are the causes that occur higher up in the lower GI tract, especially in the sigmoid colon and descending colon and proximally. Usually they are due to tumors, vascular malformations, and polyps. Then you have to also look at the associated symptoms that come together with passing blood in the stools. Pain, which can be a common condition, accompaniment, colicky pain due to infection or skin lesions. Mixed with mucus, especially in inflammatory conditions, infection, and tumors. Abdominal symptoms, especially cramping pain due to blood in the intestinal lumen, causing colicky abdominal pain. And symptoms related to the primary cause. Example, cancer, they tend to have constitutional symptoms of loss of weight and lethargy. This chart shows you the importance of taking a good history in coming to a diagnosis of the cause of lower GI bleeding. Hemorrhoids usually bleeds after defecation. Fresh blood drops on the stools. Sometimes frank spurting of the blood after defecation. Occasionally, it presents as a lump coming out of the anus due to the prolapse. Hemorrhoids, which causes perianal discomfort. Anal fissures, usually the blood, fresh blood, strict on the stools. And the most important thing is associated with sharp pain, sometimes severe. You start with defecation and last for hours after that. Inflammatory bowel disease is classically blood, mucus, and diarrhea. Painless unless coexists fissure, and systemic symptoms may occur, like such as low-grade fever. Okay, now what are the physical signs? Physical signs can be external, related to these conditions, that can be easily excluded by local examination of the anal region. Perianal conditions, anal varix, thrombosed anal veins, fissures, and prolapsed bowels. Signs can also be related to the blood loss, like anemia, pallor, hypovolemia, abdominal distension, abdominal tenderness, and rectal examination, which in fact can exclude most of these conditions in most patients. And the signs can also be related to the primary cause of the bleeding. Abdominal mass, if it is a tumor that causes the bleeding. Tenderness and guarding, if it is diverticulitis causing the bleeding. If it is cancer, you can have loss of weight or emaciation as the signs indicating it is related to the primary cause. It's also important to distinguish some upper and lower GI bleeding. In upper GI bleeding, sometimes can be mistaken for lower GI bleeding. Sometimes the diagnosis may not be that easy, but it is important to take a good history. From the history, upper GI bleed usually give history of pelvic ulcer disease, alcoholism in varices, retching and vomiting in pylori-wise tear, medications such as anticoagulants, antiplatelets, and NSAIDs, which can cause ulcers. Okay, these will be the classically if these symptoms are there, they're usually due to upper GI bleed. Lower GI bleed, on the other hand, may have previous colon cancer, history of previous colon surgery, history of known diverticulosis, and known hemorrhoids. As for the symptoms, upper GI symptoms accompanying upper GI bleed will be nausea and vomiting, hematemesis, melena, and rarely hematochezia. Okay, hematochezia or fresh PR bleeding is rare in upper GI bleed unless the bleeding is massive. Whereas symptoms of lower GI bleed usually are abdominal pain, or painless passing of blood, hematochezia, passing of fresh blood per rectum, and melena, which can occur but is less common in lower GI bleed. The investigations for lower GI bleeding. First, the routine investigations, which include chest X-ray, renal and liver function tests, ECG, and especially important is your hemoglobin and hematocrit and the coagulation studies, especially prothrombin time, clotting, and bleeding time, which are very important in such bleeding cases. Specific investigations include, most important, endoscopy, and the mainstay of investigation and treatment is colonoscopy. Okay, a colonoscopy is a must investigation for patients with lower GI bleed. Sometimes upper endoscopy should also need to be done if you are unable to exclude upper GI bleeding as a cause. The next is your RBC scan. This is a radioisotope tagged RBC scan, which is done by withdrawing the blood from the patient, tagging his RBC with technetium-99 radioisotope, and then re-infusing this treated RBC into the patient and follow up with radioisotope scans over the abdomen. The important thing is the patient must be bleeding at a rate of 0.41 mils per minute. At this rate, then the test can be positive if there is a bleeding in the GIT. The next is angiogram. Angiogram is also the mainstay, is one of the important investigations for lower GI bleed. It can be either a CT angiogram or direct catheter angiogram. Angiogram is capable of detecting bleeds as low as 0.5 mils per minute. In order for the angiogram to be effective, the bleeding rate must be at least 0.5 mils per minute. Otherwise, it will be negative. Okay. The original direct catheter angiogram also gives the option of therapeutic use, like embolization of the bleeding vessel. Okay, whereas the CT angiogram, which is commonly done these days, is much easier, non-invasive, and easily available in most hospitals. Another new investigation is VCE, video capsule endoscopy, okay, which involves the ingestion of a video capsule containing video and other recording mechanisms, so that it can take videos and pictures of the gastrointestinal tract as it travels from the mouth to its exit at the anus. I put here the special investigations, which include the video endoscope, angiogram, and RBC scan. These three are not routine investigations for lower GI bleed, but it's done when necessary, depending on the severity of the bleeding. Again, I must emphasize colonoscopy as the mainstay of investigation and treatment. It is not only diagnostic to detect the source of bleeding, it is also therapeutic, as it provides the means for the various endoscopic procedures to stop the bleeding. Okay, this is what the endoscopic picture of a diverticular disease. Okay, the diverticulum occurs on the left side of the colon. The sigmoid is the most common site, and the descending colon. Together, they're more than 2/3 of the diverticular disease are confined to this area. Diverticular are acquired diseases which consist of outpouching of the descending colon and sigmoid colon due to aging process. And this, when you open it, you will see the openings of this diverticula. Here, colonoscope picture showing multiple openings in the mouth of the diverticulum. Okay, the bleeding occurs within this diverticulum, in the dome of the diverticulum. Okay, this is a schematic representation of what a colonic diverticula is all about. It's an outpouching of the wall of the intestine, large intestine, through weak points in the wall of the large intestine. Okay, and these outpouches are peculiar in that they do not contain the full thickness of the muscle layer. There's no muscle layer covering that. As such, the blood vessels that enter to feed the intestine are exposed to erosions and other destructive forces, and causing hemorrhage and bleeding. Okay, you can see here the muscle layer, muscularis here, stops short here. And where the diverticulum forms, this is the mouth of the diverticulum, this is the dome of the diverticulum. The blood vessel that's supplying it has been stretched out, and as a result, easily eroded by the diseases or the processes that take place within the lumen of the diverticulum. Okay, here is a colonoscopic picture of a bleeding diverticulum. It's the ostia or mouth through which the blood oozes out. Here it shows multiple diverticula in the colon which have stopped bleeding. Okay, you see here, stop bleeding. Here also has stopped bleeding. So these are pictures of bleeding diverticulum. Okay, these are pictures of angiodysplasia, which are actually venous or capillary ectasias in the wall of the large intestine. Okay, here there's a small angiodysplasia, and over here it is a much larger and more complicated angiodysplasia. These occur commonly in the right side of the colon, in the cecum, and especially your ascending colon. These again are prone to bleeding due to erosions and corrosive actions within the lumen of the colon. Okay, this is a picture of a malignant lesion of the colon, carcinoma of the colon that is ulcerated and bleeding. Okay, it's a malignant bleeding ulcer of the colon. These are another two pictures showing here another carcinoma of the colon which has got bleeding. See, you can see some blood stains, and over here is a malignant polyp, also evidence of recent bleed here. Okay, polyp. This is a CT scan film, CT angiogram film of a patient with lower GI bleed, where there's extravasation of contrast into the lumen of the descending colon. Okay, the arrow shows to that here. That means there has been some bleeding in this part of the colon. Here again, you see the arrow showing you extravasation of contrast into the lumen of the descending colon, which is a sign of bleeding in that area. Okay, this is another film CT scan showing you CT angiogram is showing you bleeding into the lumen of the colon. Okay, next we come to miscentric angiography. Miscentric angiography, in this procedure, the bleeding rate of 0.1 to 1 ml per minute can be detected. And so you need a minimum blood loss at this rate for it to be detected on an angiogram. Selective angiography is done by catheterizing the arteries concerned selectively under the fluoroscope guidance. And these arteries are the superior mesenteric and inferior mesenteric. And this therapeutic is also therapeutic by embolizing the bleeding vessel. Okay, here this is a inferior mesenteric artery supplying the descending colon here, descending and sigmoid colon. Okay, so there's a leak of contrast here. The arrow shows here the black substance here, and this is a contrast that has leaked into the lumen of the descending colon, indicating the possible site of bleeding in this patient. Okay, this is known as the catheter angiogram, where a catheter is passed into the duodenum, into the aorta, and cannulating the SMA or the IMA, whichever the need may be. Okay, this is a SMA angiogram. Okay, to cut the superior mesenteric artery is cannulated and the dye injected, and you can see a leakage, the extravasation or leakage of dye in the right side, okay, in the ileocholic artery. So you know the site of bleeding is in the cecum or descending colon. This shows you a RBC scan. Tagged RBC are injected into the patient, and then scan done over the abdomen. Okay, and then you see there is a extravasation of this tagged RBC in the right ilia fossa region here. Okay, this is the ilia arteries, and this is the aorta. Okay, so here, that means you know there is some extravasation indicating there's some bleeding in the right ilia fossa region, most commonly in the cecum or the descending colon. Okay, this is another view of the same extravasation or leakage. Okay, here again, it shows you another leakage of that RBC, tagged RBC, lower down, probably in the sigmoid colon or even rectum. Okay, just a summary of these three special investigations of lower gastrointestinal hemorrhage. Colonoscopy is the most important that must be done within 12 hours in stable patients without large amount of bleeding. So stabilize the patient and proceed with colonoscopy. Selective visceral angiography needs 0.5 mils per minute of bleeding in order to be positive. It is sensitive, 40 to 75% sensitive, if the bleeding is occurring at the time of the examination. Tagged RBC scan can detect bleeding at 0.1 mils per minute. Therefore, it is more sensitive than your angiogram. Okay, 85% sensitive if the bleeding continues at the time of examination. The drawback of tagged RBC, although it's very sensitive, the drawback is it's not accurate in defining the left versus the right colon. So that causes some confusion as to the localization of the source of bleeding. The last special investigation is VCE, video capsule endoscopy. This is done by a fasting patient swallowing a capsule. Okay, a capsule which is made up of these components: a camera unit, a lens, camera lens, light source, microchip, and batteries, and also a transmitter. So this capsule traverses the length of the gastrointestinal tract from mouth to the anus, and as it does so, it takes pictures and videos as it traverses the length of the gastrointestinal tract. And these images are transmitted through this antenna to the external recording devices which are strapped to the patient. So thousands of images are usually transmitted to this recording device, which are then downloaded and analyzed to see any abnormalities that was detected. The capsule is finally naturally excreted. This is a very interesting and effective mechanism, but the problem is it is costly, not easily available, and also it takes time for the analyzing the images, the thousands of images that are recorded in this capsule. Therefore, this is not very ideal for patients with massive bleeding, but it is very useful for patients with slow recurrent bleeding on the lower GI tract. Okay, these are the various components or the contents of the capsule: image sensor, batteries, antenna, transmitter, radio frequency transmitter, a magnetic strip, and also LED lights. These are the various marketed capsules that are available in the market today. Okay. This is what happens after the patient ingests the or swallows the capsule. It travels throughout the intestine and finally ends up in the descending colon or sigmoid colon here before being excreted. And these are the images transmitted by the capsule to the recording device, which need to be analyzed by experts so as to diagnose any abnormalities that may be conveyed. Okay, once this has been done, examination has been, investigations are done, and diagnosis established, then you need to clinically assess the patient for further treatment. Okay, this is done through a good history, recording the amount of bleeding, length, duration of bleeding, and also symptoms of severe blood loss like tired, giddiness, and breathlessness. Then a thorough examination is necessary to evaluate the mental status, pallor, lethargy, breathless, and cyanosis. The BP, pulse, and the cold clammy extremities are important indicators of the severity of the bleeding. Other parameters include the blood tests like hemoglobin, renal and liver function tests, ABG, and chest X-ray. And also it's important to get details of the premorbid conditions of the patient, the medical illnesses he or she has got, and the drugs, especially anticoagulants, that he may be taking every day. The Glasgow Bloodspot score and the Rockall score, the first for need for intervention and second for the prognosis, are also important scores used for upper GI bleeding assessment, which again can also be used reapplied for lower GI bleed as well. Once you assess the patient's severity, you can classify the severity into mild, moderate, and severe. Next, we come to the management of lower GI bleeding. First, resuscitation. As in all cases of bleeding, initial treatment is resuscitation. Replacement of IV fluids and electrolytes. Sometimes may have to give crystalloids, colloids like Hamacel or dextrans, especially for those with signs of shock. Blood transfusion is an important part of the initial treatment. If there are indications for blood transfusion like severe anemia, hypotension, and impending shock, then I think blood transfusion is warranted urgently. Supportive treatment of nasal oxygen, nasogastric tube to aspirate the blood, whatever blood that is being in the stomach, and urinary catheter with input-output chart. H2U or ICU monitoring closely the pulse, BP, and oxygen saturation. If the BP is low and is hypovolemic, and central venous pressure monitoring may be necessary. Next, we come to the definitive treatment. Definitive treatment is endoscopy. These patients must be subjected to endoscopy, and the rest of the findings depend on the endoscopy. Endoscopy not only diagnoses the condition, it will also to help into the treatment or to stop the bleeding, such as using ligation, application of clips, endo clips, cautery or heat probe to cauterize the bleeding vessels, or use of injection adrenaline to cause vasospasm and stop bleeding. Angiogram is another possibility. If there is need for angiogram, this can be done, and at the same time embolize the bleeding vessels to stop the bleeding. If these are not available or are unable to stop the bleeding, then you go for surgery. Usually open exploration to identify localize the area of bleeding, and then follow up with segmental resection of the segment that is bleeding, of the colon that is bleeding, and if not necessary, if unable to find the source of bleeding, then a total colectomy may have to be done to save life. Hartmanns procedure with temporary end colostomy is another possibility for emergency cases. Okay, these are some of the pictures to show you the endoscopic procedures. Application of endo clips here, you can see here, and here the openings of the diverticulum. Okay, so they apply clips around the base of the diverticulum to clip the vessels. Okay, this is how it's happened. This is the base or the fundus of the diverticulum where there's a bleeding vessel. So these can be clipped on either side to stop bleeding. This is injection of adrenaline. Here we have given one injection here. One site has been injected. Another site is being prepared to be injected. So adrenaline injected at the base of the bases of the bleeding diverticulum will stop further bleeding. And this is angiodysplasias, and these are dilated veins which can be cauterized. Best way, easiest is to cauterize and stop the bleeding. Okay, heat coagulation or cautery to stop the bleeding. And if it is a bleeding polyp, then endoscopic, colonoscopic polypectomy will be a ideal choice. Okay. This is how polypectomy is done. This is known as a snare, which is a loop around the base of the pedicle of the polyp, which is then snared. The snare is tightened to cause ischemia, and then it is using cautery, it is transected. So the polyp is removed. So this is known as endoscopic polypectomy using the snare technique. Surgery for lower GI bleeding, segmental resection of the bowel. That means you remove the part of the bowel, segment of the bowel where the bleeder is, okay, so thereby removing the source of bleeding. If it is a small bowel, you can go for resection of the small bowel. If it's a large bowel, you go for some form of colectomy, hemicolectomy or total colectomy. Again, to removing the segment that contains the bleeding vessel. And the other one which I mentioned, Hartmanns procedure, especially used for emergency, where the rectosigmoid is removed, rectosigmoidectomy plus temporary colostomy. Okay, this is your Hartmanns procedure. Okay, this is the rectal stump, this is the descending colon, and here rectosigmoid colon has been removed, resected, and the section and the resected segment is removed. Thereby the bleeding is controlled. After controlling the bleeding, then what we do is you close up the anorectal stump here, which is the stump B here, rectal stump, and leave it. And then the end A, which is the end of the descending colon, is then brought out as a temporary end colostomy. Okay, so Hartmanns procedure is the resection of the rectosigmoid colon with closure of the anorectal stump and formation of an end colostomy by the descending colon. This is, then you wait for a couple of weeks or couple of months until the patient is stabilized and there's proper healing and the area of resection is healed, then you go back and undo the colostomy and rejoin with the rectal stump, thereby establishing continuity. And this operation is called Hartmanns Procedure. Okay, this is a diagrammatic view of Hartmanns Procedure. This is the rectosigmoid colon, which has been removed. The anorectal stump is sutured and left behind, and your descending colon, the end of the descending colon, stump C, is then brought out as a colostomy. Okay, this is a summary flowchart to show how to manage a patient with lower GI bleed, especially acute bleeding. Okay, once after the patient has been assessed, initial treatment given, you assess it. You classify it into 3 categories. Okay, that is stage 1. Okay, assessment: mild bleeding, moderate bleeding, or severe bleeding. Okay, for mild and moderate bleeding, so the next stage is the scope stage, colonoscope stage. Okay, so for mild and moderate bleeding, you will subject the patient to a colonoscopy. If you see something positive, some positive lesion causing the bleeding, then you subject the patient to endoscopic treatment. Okay, heat probe, diathermy, then or using injection adrenaline, or even endoclips. These are the 3 things you can use to stop the bleeding. Okay, if it does not stop bleeding, then you may have to go for surgery, open surgery, and resect the affected segment of the intestine. If on colonoscopy it is negative, then you subject the patient to a RBC scan or a video endoscope, okay, video capsule endoscopy. And if this finds the source of bleeding, then you subject the patient to surgery and do the necessary resection. For severe cases, okay, and this is a stage of investigation, special investigations, and endoscopy, angiogram, or RBC scan. Okay, in cases of severe bleeding, you do not have time to go through the colonoscopy this process here. You have no time because you have to act fast to save life. So you do a CT angiogram. It's the easiest, fastest, and non-invasive procedure. If you find a bleeding point, this is positive, then you can give the patient vasopressin to cause vasospasm and thereby stop the bleeding. If this fails, then you can proceed on to do an embolization of the bleeding vessel. If there's you cannot find the source of the bleeding, and the patient is still not stable and patient is still bleeding, then you subject the patient to an intraoperative colonoscope. You take the patient to the OT, and ready for operation, you do a scope, identify from where it is bleeding, and then open up to to do the necessary resection in open surgery. So this is a 4th stage, okay, of surgery. Surgical stage is the 4th stage. So it is this 4th stage: assessment, scope, investigation, and surgery. This is simplified version of the flowchart to show you the management of lower GI bleeding. Thank you for your attention. I hope this short talk would have enlightened you and made you understand better the topic of lower gastrointestinal bleeding. Till we meet again in another session, thank you.